was she had chapter 20 and different wrong chapters peppered throughout the lecture. So I corrected them all in my PowerPoint, in the PowerPoint, her PowerPoint. I also have, I downloaded and I looked at all the PowerPoints, but the ones from Lippincott, because they're really good. I'm going to post them. I talked to Leslie Giles and I said I will put all of those 4 PowerPoints in Moodle just to give you extra information. I will not ask you a test question, and nor will Leslie Giles on anything that isn't talked about in class and the PowerPoints that we have from her. But I just want to let you know, I really like those. The other thing is I have a nice case study, so I'm going to try to get through this lecture, do the case study, and then try to do some more of the adolescent, because I didn't do the adolescent, finish the adolescent one. So, I have marked in my lecture to talk to you, to point out every single time that it's not chapter 20, that it's another chapter. Okay? And I really do, for information for you, for studying for the final, for you studying for your NCLEX, I just thought you needed more information than what was in the lecture. So I'm going to put those in there, use them as much as you want, okay? So I'll just give you the other PowerPoints as well, but I'll do that today afterwards. And also, yes?
Will it say in the study guides on Moodle what chapters we're responsible for? Like, are those chapters?
The chapters are 17, 18, 19, and 20. You're
Okay.
responsible for all those 4 chapters.
Okay.
However, I just really like the other, I think for beginning students, for new students, first year students, I thought the PowerPoints were good. Her information is good and it's accurate, and I've got stuff on different tables to show you. Some of the tables she's had there, they list the wrong chapter.
Okay.
So I have the notes to tell you the right chapter and the pages on it, okay?
Thank you.
Yes.
So for example, the first slide is from chapter 22. Is that?
That's not 22, that's from chapter 18.
Okay, so that's a typo on her slide.
It's not a typo. These are her notes. She created this chapter from the previous Hinkle textbook. And it was chapter 20, 21, 22, and 23. Okay, that's the problem. It's not a typo. It's she didn't update those slides where she updated her class study guide. Okay? And I didn't realize that until this weekend, and I think I just explained it to you now, and I made all the notes in my things so easy to study. Okay? Did anybody not sign this? Okay. You can pass it back to some people back there that didn't sign it. You'll have to just yell or something and call one time, okay? So, and a lot of the respiratory function, the chapter that's on respiratory function, I covered a lot of that in oxygenation. I covered, I will be covering more of it in the blood gas interpretation, that's like the last lecture, I think, anyway, so. Okay. See if it follows me. It's not gonna follow me. Yeah. Okay. Let's see. All right. So key terms, and it's not chapter 22. It would be chapter 19. Chapter 19. Okay. Is that the one that's? No, chapter 18. Chapter 18 is upper respiratory. Chapter 17 is assessment of the respiratory system. So I'm dealing with. I've got mostly chapter 18, and I've got some things in chapter. I'll go through the slides. I'll go through some of the chronic ones too. Okay, but all right. So epistaxis, what's that? Nosebleed. Who saw the nosebleed in? Who saw the nosebleed? They went to interventional radiology in the cath lab. Whew, that was incredible. This woman had an arterial nosebleed. She was 35 weeks pregnant, I think. 35 weeks pregnant, she had an arterial nosebleed, which means it doesn't stop.
Just so you know.
Cannot get the pressure on it. So they had like a big
Do you want me to pass it?
type thing in there putting pressure on it, but it was still leaking a little bit, and so she was, of course, that was going a post-nasal drip, and she was swallowing it, and blood is incredibly irritating to your stomach. So she was having trouble eating, she was having an upset stomach, and probably vomiting, which wasn't helping her, increased pressure when she would vomit and caused it to bleed probably more. And so they tried to get in there to actually, they went up with a catheter actually through the wrist, up in through the heart. so uncomfortable, this is really, she had to lay on her back. They tried to tell her hold off on it until she had a baby. But can you imagine having arterial epistaxis and she's having a baby and pushing, and that increases your blood pressure, right? Think about, that's probably going to be a problem, but they felt it was better to have the baby out, that sort of thing. Anyway, so wound up that they offered her a couple of times to stop doing the procedure, and she said, no, because I can't stand this anymore, you have to fix it. Well, interestingly, whatever little drug they take to blast in the area to clot the artery to stop the nosebleed, one of the side effects, bad side effects that could potentially or possibly happen was blindness. I was like, I don't think I would have chosen that. So anyway, but she was losing her mind literally with this whole situation. She wound up right toward the end, she said, I can't do this anymore. Because what happens is the baby, your uterus is laying on your abdominal aorta, and it makes you extremely uncomfortable, and you keep wanting to turn, and she couldn't because she was and it was just awful. So it was becoming increasingly more just uncomfortable for her, so she had to quit. But it was very expensive. They scan every little piece of equipment that they use, and so somebody had to pay for that. But anyway, so just very interesting. Epistaxis, think about it, a bloody nose. They talk about the treatment of the bloody nose in the chapter, and they have laryngitis. How many people have laryngitis in your lives, right? Most of you, a lot of you. Now, why would baby, when you get exposed to croup, your child or something, a baby will get the same thing that you are exposed to, get the same cold, and your symptoms are you're a little hoarse, and their symptoms are that you're a little hoarse, and their symptoms are they're struggling breathing because you decrease their airway significantly by the swelling in the larynx. So there's a video that most of you have seen that show the difference in what happens when the swelling in the larynx in a baby versus an adult, and why this happens. So it talks about the number of alveoli. They have so many few. They have more surface area per body weight. So all these things, their oxygenation needs are much higher, and so they struggle more if they have any kind of respiratory illness as a baby. Anyway, so laryngitis, that's why you had just a hoarseness or whatever. Rhinitis is just runny nose. It's due to allergies. It could be due to sensitivity to something, whatever. Tonsillitis, we have an expert in the class on tonsillitis. She had to have her tonsils removed. If anybody has any questions, she's available after class. Chest percussion. Does everybody know what chest percussion and chest drainage is? Chest percussion, does everybody know what chest percussion is? Okay, when you have respiratory therapy come, and actually they have to teach the nurses in pediatrics, we had to do it, we had the baby up, and a lot of times the PT couldn't come at that time. And I actually, way back in ancient history when I was a staff nurse at Children's Hospital, and then in the NICU, we did a lot of the chest PT. But for the cystic fibrosis patients, the respiratory therapists, they would come in like the teenagers or the 7, 8, 9, 10, 11, 12-year-olds, and they were starting to look a little older. When I first started in nursing 50 years ago almost, and they were 50 years ago, I said, I need to get 41. Anyway, so you did the math now. These children sit and talk to you about that they're not going to live very long. They actually had understood this like 8, 9, 10 years old. And it was heartbreaking. As a 19-year-old nursing student at Children's Hospital, I was heartbroken listening to them talk to them and tell me this stuff. But they would come in for what was called pulmonary toilet, and the parents don't need to know this for any exam question or anything ever. Apparently, cystic fibrosis patients, especially the older ones, they'll have a particular bacteria growing in them, it's a germ growing in their lungs, that is something that's in rotted onions. No idea how it gets there, no idea why, but this is how unique it was to treat them, these patients. But they would come in for what's called pulmonary toilet, and they'd be blasting them with antibiotics and to clear their lungs, and they'd be doing lots of chest PT on them, like every 4 hours or so they come and do them. These kids have to have chest PT and postural drainage every single morning for the DNA, I was going to this one little girl's house, I'd be there at 6:30 in the morning, and she would be asleep, and she would be basically sleep through me doing chest PT on her. So I have to do her vital signs, listen to her heart and lung sounds, check her OT-sat, give her albuterol inhaler, and then after a bit give her prednisone inhaler and the steroid inhaler. And then I would do for like 20 minutes, I would do chest PT on her. And then I would listen to her lung, have her cough a few times, and then listen to her lungs again, assess her heart sounds, and get her O2 and everything all over again to see if she cleared it, you know. So the chest PT is this. I can do it on my leg. Okay. You cup your hands so it doesn't hurt the patient, and you're basically forcing air against the chest, which makes the secretions of the lungs move, and you tip the patient head down a bit on pillows and everything, right, or on her lap on pillows, because she's only like 6. And tip her, and then you do the chest PT on her. So you do postural drainage, so in the direction it would go, plus you do the cupping, and then you do the vibration at the end, okay? And it sounds like this. And you do this for like 10 minutes in one spot. And then you go like this with your hands to vibrate down and keep doing that a few times. So you do that every single area of the lobe of the lung. You do that, okay? And after you got through, then you would have her cough a few times and then listen to the lungs again and see if the chest PT and the albuterol inhaler, and you got things moving. Maybe sometimes they're a little junkier, but usually the aeration is not as thick, and you hear better. It's not as congested. So anyway, so just that's something you need to know: chest percussion, chest drainage system. I don't know whether they're talking about I think of postural drainage, but I'm not know if they're talking about chest tubes here. But this is not the chapter for chest tubes because this is upper respiratory. Anyway, so. Okay, the one thing that they're not mentioning here is herpes simplex virus, which is, they used to be, for years ago, people didn't worry about it that much. Now it's like, oh my God, it's a big no-no, you know what I mean? It's contagious. They didn't realize how contagious it was. They referred to it as sun blisters. Oh, you only got it if you were out in the sun, a lot of people felt. And I would see them kissing their babies with these blisters on their lips. And I would be like, and so I talked to some patient education, and they get mad at you because they don't like you to point it out because they feel bad when they get these blisters. They were spreading it. And the problem, the first time you get herpes, everybody know that the first time you get herpes simplex, the assignment sheet is going around somewhere, the assignment sheet. Okay, look up, make sure you find it. The first time you get it, it's whopping and it's really sick. And then after that, the flare-ups aren't so bad. The problem with herpes simplex too is if you have vaginal herpes, if you have genital herpes, and you give, say male gives a female vaginal herpes, and you don't know sometimes that you have a herpetic lesion or an open lesion in your vagina, and if you deliver a baby, and they go through and they get exposed to the herpes virus during birth, and it's about 2 weeks later, they start getting sick about a week later, and then about 2 weeks later they're in the ICU, and they've got herpes encephalitis, and they die. I took care of 3 babies at Children's Hospital in the ICU, but I took care of them. I was the primary nurse, and you wait until finally, after a certain amount of time, and they flag EEGs, a certain number of flag EEGs, and you would disconnect the baby and put the baby in the mother or father's arms, and you listen for the heartbeat to stop. It's not a fun part of nursing. It's very hard. So everybody has a right to be terrified of herpes, and it's usually an upper respiratory, but it can also, because of genital, I just wanted to put that piece in there. That's not in the slides, basically. So anyway, so let's keep going here. Okay, so there's upper respiratory structures, the nose, sinuses. And did you know, what did I say in my lecture? Did I say that sinuses don't appear till when? Or did I not have that lecture yet? I didn't have that lecture lecture yet. Okay, I think it's like, 8 or 9 years old that you don't even develop the frontal sinuses. So you can't have frontal headaches or sinus infections, frontal sinus infections, till you develop those sinuses. And how you test for that, because you can test for it, if someone has a cold, they have a cold for a long time, the symptoms seem to lag on, and they get eventually, like about 2-3 weeks later, they get a sinus infection because it's turned into something that needs to be treated with antibiotics. And how you would test it on some friend of yours or a relative or yourself is, first of all, if you lean your head forward between your knees and the pressure builds up here, or in here or in here, because the sinus is here and sinus is here, then you know that it's a problem, you maybe need to go get checked. But the other thing you can do on one of your relatives or friend or whatever is do this. You tap here, just have them sit and you tap there, and it's like, they like wince, it hurts, okay? So that's a real clear sign of a sinus infection, okay? So that's something that takes a while to get rid of sometimes. You have to be on antibiotics for a while, okay? So you've got your sinuses. You see those frontal sinuses in the green on the top, those top ones? I'll try to keep the cursor up. See, these are the frontal sinuses, and that's what you have, okay? This is just anatomy and physiology, but you've got to remember if somebody has, other thing that I want to make sure is mentioned in here is HPV, okay? I hope everybody here has had the HPV vaccine. If you have not, I would do it. It's up to now 40-something. They give it up to 40-something years old, like 48 or something like that. Used to be only for girls, and I loved it because you'd have them come in and you'd recommend, when it first came out, you'd recommend that the girls get the HPV vaccine because insurance was only covering it for females. Why, I don't know. But that's what the brilliant insurance companies decided to do first with it. So the fathers would come in and say, oh, no, I don't want my daughter to get that because I don't want her to become promiscuous. And you're like, why is preventing her from getting oral, esophageal, larynx, vaginal, vulva, rectal, cancers when she's in her 60s, what does that have to do with her being promiscuous? And they just did not buy it. It took a long, long time and a lot of education to finally get these parents to accept this shot. And the other was, then when they come in with the boys, oh yeah, my son's going to need that. And I'm like, who do you think you're having sex with? Anyway, okay, that was my fault. I don't think I probably verbalized it very much. But so you have esophagus, esophageal, all this stuff. So now the thing to think of, when you're looking at this, later on we're going to talk about if they have a laryngectomy. What is a laryngectomy? They've had cancer of the larynx, probably caused from an HPV vaccine, HPV infection, okay, from years and years ago. It stayed in their system and their body never really got rid of. So if they have a laryngectomy, they're going to get this removed, so they're going to the larynx removed. So they're going to have a trach down here, so that's how they're going to breathe. They're going to have some kind of physical speech therapy in order to do some kind of a vibration box to be able to speak. And this is going to be their larynx right here. The epiglottis is going to be gone, and it's going to be sealed off. But you'll see that in a picture later, okay? I just wanted to sell this because that's something that I really think a key term that should be mentioned here should be HPV virus, HPV. Human papillomavirus. I think I remember doing how prevalent is it in our world, okay? I remember doing a CME, a continuing education unit thing for my NP, and it was the article that I was doing the questions on to get points was about, they did a study on virginal college students, which I said, I thought that was an extinct creature, but anyway. So virginal college, I'm sorry, I'm very outspoken about adolescent health, okay? Virginal college students, they did swabs of them. They did throat swabs, they did swabs to see if they had HPV anywhere. And they were right, they didn't have them in all the other places, but they almost all of them, vast majority of them cultured positive with oral swabs because they were doing open mouth kissing. So think about that. That's your laryngeal, your esophageal cancers, all that stuff. If that stays in your system and you don't neutralize the virus and get rid of it in a certain amount of time, you're going to have issues. And unfortunately, sadly, the issues come out when you're in your like 50s and 60s, okay? Apparently the cancers are more common in males, but there's lots of them. I mean, it's penile, rectal, esophageal, laryngeal, oral cancers, all that good stuff, okay? So you'll see that a little bit later. Okay, and then you've got the lungs, and I know the students have had me in clinical, and I know I'm a crazy person about the right middle lobe. Where can you hear the right middle lobe? Right here. And you compare it to the right side, the left side, in the same place. Even though you don't have a left middle lobe, that's how you're going to compare those frontal lobes, okay? So you have the only place you can hear the right middle lobe is if you listen in this area, okay? And you're really supposed to go mid-axillary line, so right underneath your armpit down in the middle, and listen there. If you listen in the back, and you do very nicely listen in the back, you do not hear the right middle lobe. If you listen here, and then go to the back, you'll miss the right middle lobe. So you have to go here, and always tell your patient, I watched people, so I took a friend into the ER, and I watched people listen to lungs, and they never told him to open their mouth and breathe through their mouth. He's breathing through his nose, and all these noises in your nose go into your lungs, and you think that there's noise in the lungs. If you open your mouth and you breathe through your mouth, you don't hear those nasal noises in your lungs, so you're not confused by those sounds as a nurse or provider, okay? So what you want to do is you want to always tell your patient, open your mouth and breathe through your mouth. You know, take some nice deep breaths. And you can say, take a breath, take another breath. You tell them, you cue them. And that's a good way to assess the lungs. You listen here for about 3 or 4 breaths. You listen here for 3 or 4 breaths. You listen here for the right middle lobe. You're going to miss it. You listen here just to compare, because you always compare the sides. And then you listen going down small boxes all the way, going out a little bit when you get under the scapula, and then going down till you cannot hear anything again, which means the lungs have ended. Does that make sense to you? Okay. I think my students that have had me in clinical know all that. So anyway, all right. So you're enough about the right middle lobe. Nobody's going to miss it again. Because if you just listen along from the back and you just listen here, you've not even heard the middle lobe. You can have a right middle lobe pneumonia that you don't even know about. And everybody knows that if you take your hair and crinkle it kind of in your ear, that's what it sounds like. To help the guys out by putting, and anybody who has really short hair, and anyone in their short hair, help them out by crinkling, giving them your long hair to listen to. But the other sound is if you put milk on Rice Krispies, that's the same sound. Okay? Put milk on Rice Krispies and put your ear to the Rice Krispies, that crack, snap, and pop, or whatever it is, that is the sound you hear in lungs when it crackles. Okay, so upper respiratory structures, the nose warms and humidifies and filters the air going in. It actually helps to keep some germs out, okay, even. The septum, the bone separates the right and left. I have a septal defect because I was smashed in the face with a field hockey stick, and I love it. I think I've told my students in the past, I always tell, especially when you're looking in a person's eyes, they like all over the place sometimes looking, they don't, especially kids, and I say, oh, I broke my nose when I was in high school, so you can figure out where it's broken, and they stare at my nose the whole time so I can really assess the pupils, are equal and reactive to light and accommodation. Okay, so that's that. So septal defects, and usually people have trouble, if you cover one nostril and you breathe, you cover the other one. Like I can't breathe real well through this side, so when I get a cold, I'm pretty miserable. Sinus chambers resonate, speech located by, they resonate in the different sinus chambers, okay? And some people, sometimes they sound very nasally because they need their adenoids removed. And they can't tell what the adenoids, did they check your adenoids when they were in there? They did. Did they remove those too or not? They were fine, that means they weren't enlarged. The adenoids are enlarged. You can't see the adenoids when you look in the throat because you use a pen light. When it says when you examine a patient, oral, whatever, you're going to be looking at a pen light. You're going to look at their, remember I taught you last semester, looking at the different sizes of the tonsils, that they're flat, that means they're flat. And then you've got +1, +2, +3, +4, +4 touching or kissing tonsils. They're big like little tiny grapefruits in the back and touching each other. And that's called kissing tonsils, in case you have of times it's the sinuses that are causing this resonance in the speech, but a lot of times it's also the adenoids, okay? And they can't see those until they're in there with the patient anesthetized, usually intubated, so that they can get in there with a scope and see, and with a light and look up and see the adenoids. Pharynx connects the lungs, tonsils, adenoids, and protectors. It used to be they didn't think the tonsils served any purpose, but they really, it's now part of infection. The problem is they get out of hand and they get infections too often and they're more susceptible, so that's when they usually get removed. How you decide to remove a tonsil is they usually have like 4 or 5 documented strep cultures within a calendar year. And it could be like January to January, April to April, June to June. It's within a 12-month period, they have X number of positive strep cultures, and then they get referred to ear, nose, and throat. The other thing is if you have a child or someone snores very badly when they sleep, you want to refer them to ENT too, because they could have adenoids. They could have adenoids or tonsils and watch that they need to actually have those removed. A lot of times, though, people snoring, they're struggling with their breathing and everything. It's because usually they have very thick necks. If their BMI is elevated, that's going to cause pressure and cause you to have some sleep apnea issues. So that's a concern as well. Larynx voice box connects to the trachea, and then the cartilage is released. Okay, so what you call this is just all A and P on the left side, and then it's the different bacteria that causes stuff. One of the biggies we see a lot is, especially for what did I see it for? Mycoplasma pneumonia is very typically the cause of community-acquired pneumonia, and they usually treat that with Zithromax unless you're allergic to it, and they can look at alternatives. Okay, but those are good things to know. I am not going to ask you what germ causes what problem in a question, but it's I want you to read it so you're aware of it, or know where to look it up. You've read through it a couple of times, got it. Okay, I know where to find it if I need it, right? We're going to focus a little bit more on alveoli connecting with the capillaries to exchange gas and CO2, and we'll do that in acid-base balance. Okay, this is upper respiratory disorders. This is chapter 22. It says it's not as chapter 18, and that's my chapter today. Foreign body aspiration, choking emergencies. I had one time I went to the ENT office, and they actually had a bulletin board, and they had little tiny plastic bags pinned to the board, all the different things that they've taken out of kids' noses, lungs, throats, whatever. So, and if you have to go into the lungs to get it, you have to go by bronchoscopy to get it. So you have to, they got to semi-anesthetize the patient, make them kind of out of it. But I believe they use Versed, and they just go down in, and the patient's kind of aware of what's going on, but they're kind of not aware too. So it's like anyway. That's the other thing. When I was at Fountain Hospital, we had patients in meeting, they always call me and tell me there was a bronch today, and they let me fit like 5, 6 students, and you watch it, you could see it where they were going in on the videos. And the pulmonologists that were doing them were so good and loved to teach. So I would get the students I tell them all the questions they were going to ask them, and I give them all the answers, and he'd say, oh, your students are all so smart and well. Anyway, so I wanted the students to feel good. Obstructive sleep apnea, reduced ventilation, compressed lung. Compressed lungs a lot of times is either structural issues, a problem, inflammation, or sleep apnea related to usually obesity. Something that people really need to be aware of. So trauma, fractures, rhinoplasty. One of the things that's in this chapter that talks about the kids in soccer smashing into each other. They both have broken noses. That's not going to be the case. One's probably going to have a broken nose because they got whacked by the head of the other one. Okay? Their 2 noses did not hit each other. I don't know how both get broken noses. But rhinoplasty is just the word for going in and doing fixing the nose after it's been broken. Epistaxis is a nose ring. We talked about that. And that's wrote stuff down. Okay, So foreign body aspiration choking emergencies is a chart on page 510. It's chart 18.4, and it talks about the different instructions, and it's good to read through that, okay? And then if you look down at epistaxis, multiple factors, it's a table 18.2 or chart 18.2, and it's on page 500. And then another one, there's risk factors, is good to please look at that. It's on page 511, and this is in the current Hinkle book. This is in the 15th edition. That's page 511, it's 18.5. The other thing that it doesn't talk about in risk factors is that children pick their nose. You'd be surprised. It's like a magnet, you know? What is it? You can pick your nose, you can, what is it? You can pick your nose, you can pick your friends, but you can't pick your friend's nose. Anyway, so, yeah. There you go. But it's like a magnet. They're in your nose, and they're famous for sticking. Oh, yeah, another chart in this ear, nose, and throat office that had what they've taken out of children's noses. And a lot of times what they'll try to do first is they'll try to do what's called an angel's kiss or a mother's kiss. And mother or father can do it, doesn't matter. They would put their mouth around the nose that's not blocked, and have the child with a breath and blow. The thing sometimes will pop out of the nose and has the thing in it, but then otherwise they have to anesthetize them. I have interesting pictures of surgeries when they went in to get things. Okay, so and what happens with kids when they pick their nose, they'll scratch it by accident. Now, I'm sure none of you have ever picked your nose in this room. I'm sure of this. I think I even said this to my students that I had in clinical before. Never, I know you didn't. But when you pick your nose, if you cut on this part, it's cartilage, so it doesn't hurt. But if you pick this way, that's your septum, and it's really very vascular, and that's incredibly sensitive. How many people have gone like this by accident stuck their fingernail into their nose when they're like doing something? I don't know. Anyway, it's so painful. But what happens is the kids will get repeated colds or something, a lot of colds, and they just get irritated from sneezing and having being congested and everything, and then they'll be picking their nose, and then they'll scratch a blood vessel that's very close to the surface, and that blood vessel will open up and bleed. And so what happens is they usually have to go in, and a lot of the pediatricians I work with, we hold the child down and they cauterize that particular spot, because the nose was repeated day after day, and it was how they can. You can't do that with arterial. You can only do it with venous. Most nosebleeds are venous blood anyway. Let's see. Is there something else? So yeah, so they damage and they repeat nosebleeds. I addressed that. Edema, foreign body, allergic reaction surgeries, nasal and laryngeal obstructions. Cancer of the larynx, laryngotomy is more common in men over 65 years old. It's carcinogens. Alcohol is a factor. Smoking is also an factor. Sometimes if you've been exposed to like asbestos and things, and that's also going to be chapter 18.4 and 5. It's going to be the tables for 18.4 and 5. Okay? And that's, I don't have the page numbers for those, I'm sorry. This picture is much clearer if you look at it in the book, because this is cut off. You can see that it's cut off on the right side, here on the right side. So that's chapter 18 in the Hinkle text, the edition, 15th edition. It's on page 512, and you'll be able to see it more clearly. And this is the little case study she does about two kids smashing into it, and they both broke their noses. I mean, they could have both hit each other's heads, I suppose. Anyway, also assume you're the only healthcare provider there, because you probably are. The only time I had to really intervene like that in one of my kids' soccer games was they were getting, I think I told my students this in clinical, they were getting these two kids out. They just smashed into each other. And you heard their heads crash into each other. You could hear the sound. And they were playing soccer, and they were both down. It was a high school soccer team. They were big boys. And I told them not to move them to call 911. I told them not to move, especially this one kid that was really complaining of neck pain. And I said, no, we're not moving. And I kneeled down on the grass on the field and held his head. And I said, you're not moving until the ambulance gets here. And the funny thing is, I think some of you know that I teach teach CPR at, down the fire station, and I know all paramedics. And of course, my friends all showed up, and they're like, what you got, Gene? You know, like this, and over again. They totally backboarded him. They put him on a backboard, strapped a cervical collar on him, strapped him in the board so he couldn't move, and brought him in to get neck films before they were going to let him move. Okay? And they said I did the right thing. So just follow your instincts. You know what you're doing. The people in the scene, oh, let's just get on the game. We get on with the game. I'm going to go home and fix dinner for my kids. When we finish the game, you know, get the kid out. At least get the kid off the cliff. You know, and I wouldn't move. So I can be tough when I have to be. And you should all learn how to do that too. All right? Let's see. Instruction. Soccer is kind of rough. I wish they had some kind of like, even if they had light padded helmets or something. That's, I don't want a football helmet on because then they'll smash into each other and kill each other like they do in football. I don't want that. But if they had some kind of a soft protector on them, it would be helpful. But their necks also get hurt. Okay, here's more anatomy. This is just this. I did not find this in the book, so if you found it in the book, you're a better man or woman than me. All right, so it's just more anatomy, physiology, you know. Okay. And then this is laryngeal cancer, which I kind of already talked about. Squamous cell involved the lymph nodes at later stages, the risks to carcinogens, tobacco, and asbestos. There are so many problems that are caused in our world by cigarette smoke. So, and the other thing is I wanted to make sure, again, I mentioned human papillomavirus because that can cause all these cancers as well. It wasn't mentioned in the slides, so I wanted to make sure it was mentioned. So alcohol, age, race, gender, vitamin deficiencies, manifestation, hoarse, raspy voice, cough, sore throat, those, and then, I don't know, not all the signs, they might be later signs, so that means. Laryngoscope, laryngoscopy, exam of the lymph nodes, bearing, swallow, CT scan, MRI, needle biopsy to define and to be able to know what kind of cancer it is, so you know how to treat it, and then you want to eradicate the cancer. We try to preserve swallowing and voice functions, but sometimes you have to eliminate that for the total laryngectomy. And that's going to be, you're not going to have your voice box anymore. That's when you get the person with a permanent trach. It's the only way they're going to be able to breathe the rest of their life. And to talk, they press on something, usually they can make a sound. Or they're going to use writing, reading, word boards, things like that initially when they're first figuring out how they're going to handle this. Okay, here's more. This is showing that when you have the larynx, here's normal, and this is after you have a laryngectomy. This is going to be the tracheostomy. So this is totally surgically sealed off. There's nothing. It's the only thing that's open is the esophagus to swallow, to eat and drink and swallow food, but not to take any breaths. Excuse me? When do they do what? Oh, they take the O out of that. That's patients, if they're intubated. If someone's intubated and they have to be intubated certainly the time, you're irritating the tissues with the endotracheal tube. So eventually, if they're going to have to be long term, and there's a problem, like there's a stricture, and they're not able to fix it or whatever in the larynx, they have to remove it, then they have to put in a trach. But if anybody is long term, they're not going to turn them off yet, shall we say, but it's going to be long term. They will have to put in a trach because you can it's only like a matter of weeks that someone can be intubated with a tube directly from through their nose or the back of their mouth into their lungs, okay, to help them breathe and get a better. But then they go to the OR. So it's because you can't have an endotracheal tube in too long. It'll irritate and might perforate the larynx. So that's why they would go to the OR and they do a trach. That's, again, I've already explained it, kind of surgical removal, all the parts of the larynx and surrounding structures, larynx, hybrid, bone, epiglottis, cricoid, 2 to 3 rings of the trachea removed, permanent loss of voice and diverse airway with a permanent tracheostoma, that's right here. Sometimes people have a temporary stoma because something has to heal, or they've done surgical and they have to do temporary trach. So they'll actually have that with kids. Usually they often have a significant scar and you can tell that, but they'll probably have plastic surgery and fix it too, so that's possible as well. So you have somebody that might have a temporary trach, and then then they'll reconstruct or fix it or whatever, do whatever they can to be able to put them back together again. I don't know what that does, however, to their voice box and their lungs. Potential complications, respiratory distress, hypoxia, hemorrhage, infection, wound breakdown, aspiration, tracheal stenosis. So those are all the complications. Assessment of upper respiratory structures, common symptoms. And you should know all the names of these, don't you? You know all of the definitions of all these, what they mean. It comes to mind when you see that. Hemoptysis, what's that? Spit up blood, right? Heme. Okay? Orthopnea, what's orthopnea? Yeah, a lot of times people, especially again, if they have an elevated BMI, they might really struggle if they're lying flat. They have to have the head elevated or even bolt upright for a while to help them. And stridor is what happens when you have like a croup, or more often with, it's more like a barking seal cough with stridor, with a croup. But if you've got an obstruction, that's when you have stridor. And it's like, it's an inspiratory, high-pitched sound, okay? Cough, wheezing, sputum, pain, this, you guys know what those are, okay? Just wanted to clarify anything else. So you're taught in first semester, first year of nursing, what do you do with patients having trouble breathing? Sit them up, right? Sit them up, sit them way up. Not just up a little, 30 degrees, or sit them up, okay? Or have them stand if they can. Okay, physical assessment, general appearance, I'm going to catch up to myself here. Okay, so general appearance, probably the things everybody knows what that is, because you did that in the skin last semester with me. Nail it, spongy, angular shape, it's funny looking. You can look it up with Google cupping and you'll know what we have, right? A lot of children with chronic heart disease, babies that are born with congenital heart anomalies and have some repair, but they can't repair at all. They'll have clubbed fingers. Kids with cystic fibrosis have poorly colored fingers. They look like little, clubs at the end of their fingers, and they're rounded, and the nail beds are very different. Cyanosis of blue is not a reliable sign of hypoxia, so you want to do obviously assess your O2 sat, and you want to make sure that you provide oxygen if a patient as their saturation is below. When you're accepting, if a baby's at rest and they've got respiratory issues and you're following them because they're in the croup or in whatever, or RSV, they'll tolerate like 88 as long as the baby's really calm and quiet, but they want it to be like 90 or above, okay? But you're not pushing for 100. Now remember what I said last semester. If your O2 sat monies, little O2 sat monies measure up to 100, they can't go any higher. You could be actually giving them, your O2 sat could be higher, and that's causing an overdose of oxygen, and that's not good, okay? So you want to make sure that it's at 97, 98, 99, that you see those numbers and not 100 all the time. You want to make sure. So you're going to back down on the O2 till you get into those numbers. But it's not, if you see 100 at a pulse oximeter and you're not giving the child oxygen, is that an issue? No, because you're not giving them any additional oxygen. That is what it is. They've got great oxygenation, their lungs are great, okay? But if you're providing oxygen, that's a drug, and you need to make sure you're not giving too much of it. And the only way you can know you're not giving too much is keep it like 97, 98. Someone with COPD, you want it to be a little lower, right? So you want it to be like 92, 80. They'll give you parameters like 88 to 92 or something. They don't want it to even go into 95. Because then you're kind of wiping out their O2 drug. Everybody understands how that works with COPD patients? O2, if you don't, I'll explain it. Anybody wants me to explain it again, I will.
Yeah.
Okay, so what it is if somebody has COPD, they're breathing faster usually. They have to struggle to breathe because their lungs just aren't working as great. They don't have the surface area and alveoli and everything that you have and I have. They breathe, you're all sitting here, nobody can hear anybody breathing, right? Can anybody hear the next person next to them breathing? If you can, that's bad. So if you can hear somebody breathing, they need to be seen, okay? So it's usually, yeah, right, seriously. So if you, unless it's just nasal congestion, like little kids blocked up and they breathe through their nose and all that, so tell them to open up and breathe through their nose and then you can't hear them breathe, right? Unless they go, and I tell the kids, no singing, you try not to lift your shoulders up and down, just in and out. Like, why? And then you can really assess their lungs. You have to explain it to them. You'll know anyway, so some of the COPD, you people are all taking a breath when your brain tells your lungs to take a breath. You don't even realize it. You don't have to think about it, right? Okay? And what's telling you to take a breath is what is the chemical that's making you take a breath? Carbon dioxide, your CO2 is built up a little bit, your brain says, oh, CO2's coming up there, okay? People with COPD have lost that drive. They're only taking a breath when their oxygen gets low, their brain tells them to take a breath. They wiped out their CO2 drive. They damaged it, okay? So if you give them too much oxygen, what are you going to do? If you're giving them supplemental oxygen, what's going to happen? Are they going to breathe? No. So are they going to breathe off CO2 at all? No. So that's why you have to cut back on the oxygen. Does that make sense? Did I explain it the way that makes sense to you? I'm preaching to the choir. Okay. Inspect the mouth, nose, larynx, trachea, exterior thorax. You're going to do all that. You're going to check it with a pen light or a flashlight. You're going to look in and check on that. You want to look for any inflammation, any redness, any swelling, any exudate, meaning pus is actually coming out of the tonsils, and that's possible. Has anybody ever seen what hand, foot, mouth disease looks like in a kid's mouth or a person's mouth? Okay. And then they've got the rash on their hands and on the soles of their feet, the palms of their hands. It's going around now, just so you know. Somebody's kiddo has it. Barrel chest, that's when they get a barrel chest, that means, you know, this diameter of your lungs is bigger than this diameter. Your front back is less than the side part of your lung, your rib cage. When this gets bigger, that means they've got problems with their lungs and they've got barrel chest because they're using accessory muscles in such a way. Funnel chest is when, it's actually called excavatum, is another term, pectus excavatum. It means it goes in. Usually kids are born with this defect, and sometimes it affects their ability to play sports and their breathing and everything, and sometimes it does not. Actually, I had a nephew that had it, and they were talking about doing surgery on him, but he wasn't having any respiratory problems or anything, and so we did not do it, thank God. Because guess what he decided to become and couldn't have become if he had had surgery, because if you had surgery to fix your pectus, they crack your chest, the sternum, and they put staples in it to put it back together again. Eventually it'll probably heal, but not quite as good. He became a Navy SEAL for 23 years, and he wouldn't have been able to do any of that. He would have been able to do halo dives. Yay! I remember they talked about Captain Phillips and how they did a halo dive, the SEALs did a halo dive, so nobody could hear the plane. They dove out of the plane so high, so they had little oxygen things that they then spit out when they get down. And then one of them is attached to the engine of the dirigible, and the other, it's unbelievable. I'm like, don't even tell me this stuff, I don't know. And what happens is when they get down, all they do is they watch their watch, their altimeter on their own wrist, and they pull the parachute when they're about to hit the ground, and it just breaks the ball or hit the water, and that's what they do. And then when they do that, and the chute goes up, they jerk. And a lot of SEALs have had to have they have titanium vertebrae now in the back of their necks, including my nephew. Snapped his clavicle one time too. Anyway, so that's fun. Pigeon chest is when it sticks out, and it's just kind of a deformity, but it's not anything that sometimes bothers them. It depends on if they have surgical repair or not. But if it's anything prosthetics, advise against it until you find out, because they are handicapped by having that surgery. Kyphoscoliosis, S-shaped spine, and then palpation and percussion, you all know how to do that. Excursion, you put your hands on their back, you put your, like this, you put your hands near the spine, your thumbs near the spine, and your hands in your face, you take a nice deep breath, and your hands actually go like that, and you see that, and it's equal and even, it shouldn't be just one side. These are the things you watch for, okay? Auscultation and sounds noting the location, level, and finding. So you're listening to the sounds, and you do, there's a really good chart I think it's in the PowerPoint that I'm going to put in. You go little tiny increments all down the back and listen to the different areas of the lungs carefully. If there's a problem, then we should. Okay? Assessment risk, again, it's chapter 18. Neurological control, chapter 17. Neurological control of ventilation, we already talked about that. Oxygen transport, that's going to be your alveoli with the capillary going by and it's giving CO2 to the capillary, and the capillary giving oxygen to the alveoli, and it gets to, so they transport back and forth the gas exchange. Okay? You should know what these are, and I think most of you do. Crackle sounds like you're listening to Rice Krispies. Ronchi as rails, and stridor is what that high-pitched inspiratory stridor usually it is, or thopneu we talked about. Cacophony is when you're listening to the heart, when you're listening to the lung sounds, you ask them to say 99, 99, vibration, you'll hear it, and it should sound the same. I wrote a note for myself on that because I thought that was interesting. Orthopnea is difficulty breathing, shoulder breath, and lying flat. Really, when they sit up, I think I told you that already. This is all chapter 17, actually, when it says 20. Egophony is abnormal change in tone of voice that is heard when auscultating the lungs. So that's what egophony, that's the definition of egophony. Fremitus is vibrations of speech felt when you're feeling the outside of the lungs with your hands as tremor of the chest wall during palpation. Okay? So that's that. We're almost done with this. Okay. Let's see. Functions of respiration. You already know this. Process of gas exchange between the atmospheric air and the blood at the alveoli level and between the blood cells and the cells in the body. Exchange of gases occurs because of differences in partial pressure. So it's obviously it moves from the it moves out of the most pressure into the least pressure, right? That's how that works. Oxygen diffuses from the air into the blood at the alveoli level and it's transported to the cells in the body, and carbon dioxide diffuses from the blood into the air at the alveoli to be removed from the body by exhalation. So the oxygenation diffuses in the air and the blood. That's inhalation, and exhalation is getting rid of the carbon dioxide. Ventilation is the movement of air in the lungs, the air in the speech, alveoli to be released for gas exchange. The gas exchange. Perfusion is the filling of the pulmonary capillaries with blood. Adequate gas exchange depends on adequate BQ ratio, a match of ventilation and perfusion. I wrote a little thing for you. It's actually on page 467 in your textbook in Hinkle. Ventilation, perfusion, or BQ ratio. You are going to learn more about this next semester. I'm not going to bother you with it. You're not going to get a test question on it, but just understand that you want that ventilation, perfusion is a ratio, and that's what the BQ is. BQ imbalance occurs as a result of inadequate ventilation, inadequate perfusion, or both. So it's either or it could be both things, okay? Inadequate perfusion and inadequate ventilation. Causes would be shunting of the blood, sometimes that resulting in hypoxia, and may actually get better if you just give the patient supplemental O2. But sometimes it can happen from thoracic surgery, and most types of respiratory failure, supplemental oxygenation actually might just be able to eliminate it to fix that BQ mismatch, and you'll be all better. If you want to learn more about it next year, don't worry, okay? Focus, okay. Structures of the upper thoracic, we've already talked about most of this, okay? And bronchioles, the bronchioles is where bronchiolitis is for babies. That's why it's so they usually need supplemental or two when they're usually struggling for a few days. They usually just do blow bio too, which means the parent has to stand because it's hard to get them in a hood and they don't use tents anymore because those are dangerous. I think I explained that last year to you guys. I did explain that, you remember they explained they used to tuck in the tents really good, and then what happens is CO2 would build up in the tents. Even oxygen was going into it, the CO2 would build up, so that wasn't good. The other thing is if the O2 thing fell out of the back of the tent, they're basically putting them in a plastic bag and they're gonna kill them. So they don't do that anymore. Mostly do blow by O2 or face masks with older children and adults. But kids, babies, you can't do that with, so they do blow by O2. And it's usually humidified and that helps their lungs too. Our lungs for, anyone ever had pleurisy? Or inflammation of the lining in the lungs in between? That's painful. Maybe time to talk about this after. Okay, assessment of risk factors. Smoking. Okay, it's really bad. In secondhand smoke, you have kids with secondhand smoke and parents smoke, and they say, oh, I always smoke outside. They say, did you take a shower, wash your hair, and change your clothes before you pick up the baby every time you smoke a cigarette? And they're like, no, why would I do that? Well, then they're getting exposed to secondhand smoke because they're breathing in your clothes and your hair. Does that make sense? So they said, what are they at risk for? What are kids at risk for that are exposed to secondhand smoke? Asthma? Ear infections? Respiratory infections? All kinds of things. So please. I used to actually have a fair amount of young parents when I was at the community health center at Cape Cod, fair amount of patients that I would cover their patches and their meds that they were taking in different ways to try to quit smoking as they just had their first baby. So I think that's 22. Okay. Family history of lung disease, exposure to allergen pollutants, hazardous substances like asbestos, or certain byproducts of things that are burned. Some people, if they're near a factory, they burn something that you can get exposed to that. Poor nutrition, absolutely. And then human HIV infections and overcrowding, asthmatic immune response, and just having exacerbation of asthma. Okay, so this is, you actually have some YouTube. These are actual lungs from people that died that were smokers, and this is what they look like compared to the normal lungs, which are on the far left. Okay? Pretty amazing. Okay? Assessment of acute critically ill, intubated, monitored, intensive care unit, consider effects of narcotics. And the other thing you're going to look at is somebody's not breathing so good. Maybe you're giving them too much narcotics, okay? Maybe your narcotic dose is too high, so you do what's called a POS scale, P-O-S. It's Passero, P-A-S-E-R-O. If you Google that, you should find it. But that's something like, I try to pull that up in the hospital with the students and show them what it is. And what it is it basically looks at how is the patient affected by the narcotics? Are they able to concentrate? Are they still clearly thinking? Because then it's too much. You're giving them too much or letting them, they're going with the PCA pump, And the other thing is making sure that if someone's having struggle with breathing, their relative is, they're in pain. That's why they'll be doing the PCA pump. And then you can only do so many hits of it in an hour or whatever. I can't remember how many it is. You can only do so many hits of it. It won't let you give yourself any more after a certain amount of time. It has to be spaced out. But you'll have family members. They'll be having trouble breathing and they'll be giving them the PCA pumps. Basically, they're killing them, okay? So that's not a good idea. So make sure you take that away from the relatives if they're in the room. If somebody, what really makes you think that someone's in trouble? What if you're speaking to somebody and they're answering your question you asked them in your health assessment and they fall asleep in mid-sentence, they keep nodding off? You think their narcotics are a little too much right now? Yeah. Good. Head shaking. Good job. Okay. So assess for agitation. Sometimes they get agitated, sometimes lethargic, level of consciousness. changes in restless nasal flare, intercostal breathing. So you'll see them struggling with their, in between their ribs, their muscles, they're using extra accessory muscles, signs of decreased oxygenation. With babies, it's nasal flaring and grunting. You'll see as their big ways of showing their serious respiratory distress and need oxygen. Prevent aspiration, you want the head of the bed up so they don't aspirate. Auscultation along sounds of pleural effusion. The pleural cavity has a little bit of fluid in it, and it's in between. It's, the lungs are here, and it's got the casing that the lungs are in. And you can't, when you take a breath, you can't feel your lungs rubbing up against the inside of your body when you take a deep, big breath, because that's because you're pleural cavity, right? Just adding something in case you hadn't thought of it before. Yep. Percussion, palpation, those are other ways. I think we're done. So almost done. Mechanical ventilating terms and settings. Next semester you're going to have this. You don't need to know this. Just kind of have an idea what the definitions are. Read through that, that's all. Okay? These are different tests that you should know. You already know arterial blood gases are only taken from an artery, venous blood gas are only taken from a vein. And I give you the, when I do the base balance lecture, I will give you the conversion to know what the blood gases are. If you did an arterial, when you get a venous one, is a formula to plug it into, and I'll give you that. Pulse oxygen, sputum cultures. What's the best time to do sputum culture? Morning. And there's a specific way to do it. It actually says it. I think you're supposed to have the patient gargle, rinse their mouth good, or brush your teeth, rinse their mouth good with water, and spit, and then you have them take some big deep breaths and cough and spit that out. You don't want the oral secretions, the germs in the oral in your mouth to contaminate the sputum. So you do that. Assessment of linguistics. I think this is the last slide. So, pulse oximetry, you know, sputum culture, we talk about chest x-rays, you know. By the way, if you listen to crackles in the lower lobe, say I see you listen to the left lower lobe and I hear crackles, I'm going to, the patient's been going downhill and just not getting better over time. I'm going to assume it's community acquired pneumonia. I'm going to treat them with a Z-Pack, and sending them for chest x-ray is not going to change how I'm going to treat them, so I don't usually send them for chest x-ray. You don't always have to. If you hear you're hearing the sounds, you don't need the film to show you that that's there, because you're hearing it. So, so only if you're worried about something else. If you want to know if it's bronchiolitis, then you send them for chest x-ray, because that they can read on the x-ray with a baby. I would be more quick to get the chest x-ray. CT, MRI, lung scan, all those, bronchoscopy, thoracentesis, all that stuff. Okay? I think that was the last slide. Okay? So, we're going to do we're going to go for a break. We're going to spend about 15 minutes doing a little bit of a case study.